As I mentioned last week, we will not cover the junctional dysrhythmias. They are not common. Okay, so we will proceed with the ventricular dysrhythmias. First example is the PVCs. So this is the equivalent of PACs. If we have premature atrial complexes or premature atrial contractions, we also have premature ventricular contractions. Now, these are signal some sort of ventricular irritation. So this usually is common after a heart attack. Also, if it occurs in a otherwise healthy person, the same causes that led to PACs are also the same that will lead to PVCs. So coffee tops the list. So if you are a nervous wreck, for instance, or you do drugs, you most likely have PVCs. Okay? Again, if they are not it's not causing symptoms on the patient or the patient is otherwise healthy, they're fine. The patient will just be advised to identify and eliminate the causes. All right, so that's how we handle PVCs. Now, what do PVCs look like? It can be variable. Now, there are different patterns to PVCs. PVCs are premature ventricular contractions, so therefore they are abnormal QRS complexes. You already know what the QRS complex is supposed to look like. These are abnormal. So here, for instance, in this particular figure, this is a normal QRS right here, the one on the left. This is a PVC. Okay, so it looks distorted. And not necessarily because there's not always wider. They can be narrow, but they are, the fact is, these are the normal looking QRSs. This is not normal, does it? Does it look normal? No, this is a PVC. And you remember last week when we did PAC, what always follows a premature beat? A pause. Okay, so this one, same thing. There's a pause that follows a premature beat. So sinus, PVC, pause, sinus, PVC, two PVCs. So if you get two PVCs in a row, we call that bigeminy. Okay, two in a row, bigeminy. Three in a row, what will we call it? A triplet. A triplet. If it's four in a row, quadruplet. Okay. Now there are also patterns to this. Let's say if it occurs every other beat, we call it a bigeminy. So many patterns to PVCs. So this one, look at this. This is sinus PVC, sinus PVC. So every other beat is bigeminy. If it's every third beat, we call it trigeminy. So if it's sinus PVC, sinus PVC, meaning every third beat, it'll be trigeminy. What do you think the pattern will be if it's quadrigeminy? Every fourth beat, sinus PVC, sinus PVC. All right, so different types, doesn't matter, they are all PVCs. So the more PVCs, what do you think is the problem? Is the patient better off or worse? Worse. So the more PVCs, remember, PVCs are irritation of the ventricles. They're especially concerning if the patient recently had a heart attack, meaning after an MI, and then you put the patient automatically on a monitor and they throw PVCs, that's usually a sign that there could be another heart attack coming. Are we clear? Okay, so we always treat the decision whether or not to treat the PVC depends on the patient's condition. The patient is currently having an MI and we see PVCs. What do you think? Will we treat it or not? We should treat it, okay? Because they are, again, signal ventricular irritation. Depending again whether or not the patient is symptomatic. If the patient is asymptomatic, patient feels nothing. They will feel just like a PAC. They'll say, oh, it feels like my heart skips a beat every few minutes. Because did it really skip a beat? Yes, it did. See the pause? Okay, so that means, did the heart kind of skip a beat? Yes, because of the pause. Okay. If anything, that's the only manifestation the patient will report. Management again will be depends if the patient is symptomatic or what the patient's current condition is. Treatment would usually involve beta blockers. Here, either amiodarone or beta blockers. Between the two, beta blockers are safer. Amiodarone can tend to cause other dysrhythmias, which brings me to something I didn't mention last week. Let me go back briefly to the medications. On the drugs listed here on table 22-1, what do you notice on the side effects? What side effects are all of them have in common? What do they all do? Doesn't matter which class of antidysrhythmic it is. What do they all do? Hey, I can go down the list. What do they do? They all cause Brady? Only Brady? It's a variety of what? Dysrhythmias. So therefore, what can you say about antidysrhythmic medications? They cause other dysrhythmias. Okay, so that's what proarrhythmia means. These terms here that you see, proarrhythmic. When a drug is proarrhythmic, that means it will cause other dysrhythmias. Okay, so almost all antidysrhythmic agents are proarrhythmic. What does proarrhythmia mean again? Yeah, so they favor, okay, pro, right? You're pro-Trump, pro-Biden, so you favor, this one pro-arrhythmia, so therefore you favor arrhythmias. Okay, so I do have obstructive sleep apnea here, so I'll consider that if you got it. Let's go to the other ventricular dysrhythmias. So we've taken care of PVCs. Let's now go to VTAC. Ventricular tachycardia is a dangerous rhythm. There are two types of VTAC. It's either a pulseless VTAC or VTAC with a pulse. Treatment will depend on whether or not there is a pulse. Pulseless VTAC will be treated the same way as ventricular fibrillation, which is what? How do you treat VTAC, pulseless VTAC, or VFib? CPR and defibrillation. Okay, that's it. What does VTAC look like? That's VTAC, right? And we have, so the difference is if it's a pulseless VTAC, what's the treatment? CPR and defibrillation. So therefore, what's your first action when you see a rhythm like this? Assess for what? Assess for a pulse, because the treatment is depending on whether or not the patient has a pulse. So if the patient has no pulse, so what do you do? Start CPR and call a code. Okay, call a code, start CPR. For a patient with VTAC but has a pulse, it will be treated with antidysrhythmics, usually either amiodarone, beta blockers. It's a combination, right? So here are the common causes. We won't test Torsades de Pointes. Let me just show you what it looks like. It's another dangerous rhythm because Torsades de Pointes, which means it's French for twisting of the points. This usually precedes ventricular fibrillation or VTAC. Okay, so if you see a rhythm like this, it's almost always followed by VTAC, or VFib. Right, so that's what Torsades de Pointes means. Look at the twisting. Okay, it's like a twisted pretzel, right? There's no picture on your textbook. But as described here, Torsades-de-Pointes is a polymorphic VTAC. So the regular VTAC you see here is what we call monomorphic. Okay, so only one shape. Polymorphic is the Torsades-de-Pointes. So here are the common medications that can lead to VTAC. And again, certain antidysrhythmics can lead to that. It's also drugs that are causing vasoconstriction, vasopressors specifically, can also lead to VTAC. VFib. So VFib has no, there's really disorganized rhythm right here. So it's highly disorganized. So what's the only treatment? CPR first and defibrillation. Okay. So this is again same as pulseless VTAC. So you see that, then you call a code, begin CPR right away until the crash cart comes and you can defibrillate. Asystole, what's the treatment for systole? Asystole? Only CPR. Do we defibrillate?
No.
There's nothing to defibrillate here because there is no electrical impulse. So therefore, start CPR first, generate some blood pressure. As soon as blood pressure is generated, therefore you generate electricity. There's power now because the blood pressure will push the electrolytes, calcium, potassium, sodium, in and out of the cell again. Then you can have a rhythm. The first rhythm that comes back after asystole is usually VTAC or VFib. You'll never see sinus rhythm, right? It's always going to be VTAC or VFib if you successfully do CPR on a patient in asystole. Let's go to blocks now. Now, there are 4 degrees of AV block. Why are they called AV blocks? Well, it's a conduction abnormality, meaning somewhere between the SA node and the AV node, something is blocking the impulse, which means, is the impulse from the SA node reaching the AV node?
No.
It's not. Okay, so there are varying degrees again. First degree AV block is not really a block. It's technically a delay. Meaning, what is this time represented again? The time that it takes for the impulse to travel from the SA node to the AV node before it transmits it to the ventricles. What do you call that again? PR interval. Okay, so therefore, what will happen to the PR interval in first degree block if it's a delay? Longer than what? Well, what's the normal PR interval? So therefore, this one would be any PR interval that lasts longer than 1 big block, longer than 0.2 seconds. So that's a automatic first degree block. Because that's the only thing wrong here. Are patients with first degree block symptomatic? Very rarely are they symptomatic because all it is it will slightly drop your heart rate. Heart rate will be in the high 50s, usually in first degree AV block. So they require, because they are not symptomatic, so therefore, no treatment. Okay. So for arrhythmias like that again, what's the only thing we left for us to do? Besides monitor. Okay, identify the problem. So what's causing the block? Could be medication. So let's look at the causes. So what's usually the causes of AV blocks? So what drugs are? Okay, usually calcium channel blockers, beta blockers, these are or digoxin. Okay, see, these are the common drugs that will lead to first degree AV block. Now let's go to second degree. There are two types of second degree heart blocks. So there's type 1, which is not as serious as type 2. Let's look at the difference between the two. Here is second degree type 2. And okay, let's look at type 1 first. Okay, so this is second degree type 1. In second degree type 1, there is a progressive lengthening of the PR interval, which means the PR interval will be long, gets longer, and even longer. So first beat will be long, meaning longer than 0.2 seconds. And then it'll go even longer and even longer. And then on the fourth, it will drop a beat. Okay, so it goes long. Look at this. Is this long? Yes. Yeah, that's very long, right? That's greater than 0.2, greater than one big block. And then look at this here. So it's longer, gets even longer, and then finally you lose a QRS. You lose a beat. Okay, so this can be significant enough to drop the heart rate, probably in the low 50s, but the patient can or may or may not be symptomatic here. Yes, it's serious, but not that serious. Okay, so second degree, we monitor the patient more. Unlike first degree, we're not even worried. Second degree type 1, yeah, you watch these patients. Second degree type 2 are quite serious because look at what happens to the heart rate. In second degree type 2, what happens to your heart rate? So here the heart rate drops, right? Okay, so therefore, what's your estimated heart rate here? Just count really quickly. These are your 3-second markers here. 3, 6 seconds. So it's how many? 1, 2, 1, 2, 3. Not even 50, like in the 40s. Okay, it's already in the 40s.
But is it because the first one they had
It's before the marker.
Yeah, this is the marker.
Yeah.
They count here 1, 2, 3, 40 something. Okay, this heart rate is in the 40s. So that's second degree type 2, which is serious now, correct? Because now your heart rate is really low. It's in the 40s now. But some patients can still be conscious here, may be fine, but we should treat second degree type 2 already. Second degree type 1, we can get away with monitoring these patients. Third degree heart block is the most serious. This is also called complete heart block, or some doctors call it complete AV dissociation. Look at the description. Third degree heart block occurs when no atrial impulse is conducted to the AV node, meaning is the SA node firing? All is the saying is no atrial impulse is conducted to the AV node. So is the SA node firing?
Yes.
It is. Is it reaching the AV node?
No.
No. It's completely blocked. And what did we say last week is the role of the AV node? Is it a pacemaker?
Yes.
Yes. How much is it capable of generating? How many impulses? That's SA node. 40 to 60. Okay. So therefore, in this scenario, the AV node is a pacemaker. Since it's not getting any signal from the SA node, what will it do? It's a pacemaker. So then what will it do? it will generate its own impulse. So it's like if me and Hannah, for instance, are going out, are we still, do we have a relationship here? If let's say we were married and we have third degree AB block, are we together?
No.
Not anymore.
No.
Okay, so I'm doing my own thing. So the SA node is firing. As far as the SA node is concerned, I'm firing. I don't know what you're doing, but the AB node is not receiving it. So are we communicating?
No.
No. So that's why it's called complete heart block, meaning SA node is firing, AB node's firing. So how many do we have the same atrial and ventricular rate here?
No.
There will be a different rate. So if you look at the third degree heart block, so you have a different atrial rate. There are P waves here. See, there are P waves. But is there a QRS for every P wave? They're missing. Okay, so not every QRS will have a P wave. And the P wave will have a different rate here, meaning the patient has a different atrial rate, a higher atrial rate, and a lower ventricular rate. You need some more description. So if we look at the never mind, something's wrong with the so if we look at the P waves here, so this is the P wave, right? P wave there, P wave here. Look at the regularity. Look at the rhythm of the P wave. Is it regular?
Yes.
Yes.
Yes,
Yes.
it's regular. So you have a regular P wave. Let's look at the QRSs. So here's the QRS right here. It's not the QRS here.
They're not
What do you mean they're not regular?
Look
at that.
regular.
You also have a regular ventricular rate, but they're totally different rate.
I can use.
While the magnifying glass is not working today. All right. So you have your textbooks anyway. You can do your own measurements. So if the patient with the AV block, second degree type 2 or third degree heart block, they're usually treated with a pacemaker. Because obviously, is there a communication between SA node and AV node? No. So can this patient live on a heart rate of 30s, 40s? No, they need a pacemaker. All right. Emergency treatment though, here, initial treatment is what? Atropine first. So you give atropine, IV push. As far as pacemakers, there's really no such thing as an emergency pacemaker insertion. Are we clear? None, because we have a temporary pacemaker. I will get to that on another page. So the next few pages, we will deal with your responsibilities about patients who have pacemakers and defibrillators, particularly implanted cardiac defibrillators. Okay. Cardioversion comes up first, so let's compare again, cardioversion and defibrillation. So if you remember my quick description last week, what's the difference between these two? Is the machine different?
No.
Same machine. What's gonna make the defibrillator a cardioverter? Synchronized button. What's the difference between the two? When is the electrical shock given? Go ahead, Salgado.
I think the defibrillator is the one that happens automatically.
Okay, so the moment you press the shock button, the shock is delivered. What about the cardioverter?
That one has to first sync with the.
Okay, it'll take a few seconds. Okay, so therefore, which one is scheduled? Which one is impromptu? Cardioversion is scheduled. What about defibrillation?
You have.
Impromptu. Okay. So here, major difference again is the timing of the delivery of the electrical current or electrical shock. In cardioversion, delivery is when? Synced with the and is delivered where? When? At the peak of an R wave. Okay, it only delivers the shock at the peak of an R wave. Whereas defibrillation, anytime you press it, doesn't matter which part of the cardiac cycle the patient's heart is at, it will get shocked.
You see the movies, they go like.
Defibrillation.
Yeah.
If you do movies, please don't use movies on this one on the exam, okay? Because it's never correct. All right, it's all Hollywood no script. You know how to do use the AED, so I assume you know what to do before you press the button. What do you do first? Okay, make sure everybody is not touching the patient. Okay, you have to shout clear though, including yourself. Okay, you may be shouting clear, but you're the one touching the patient. All right, here's the reminder. This is already part of your BLS training, so just please make sure you review this.
Yeah.
And here's the cardioversion. Again, the what is done before we do this? What should be given to the patient? Is the patient here is awake, right? Because this is scheduled. We sedate the patient, and then we do the cardioversion. Okay. Do we need consent for this? Yes, because this is not really this is rarely done in an emergency. And again, the patient is awake here when we do cardioversion, so we can get we can explain, we can get consent, and then we can do the procedure. Okay? We can sedate them pre-procedure. In VTAC, pulseless VTAC, VFib, the patient's not conscious at all. So do we care about sedation? No, patient won't know what's going on. How do we prepare again? If the depending, I described it last week under AFib. So if the patient has new onset AFib, is there likely a clot there?
So.
Not yet. So can we do cardioversion right away? Yes. What about if the patient's been on AFib for more than 48 hours? Yes, most likely there's already a clot there. So can we do the cardioversion right away? No, we have to do what first? What is that test again to see if there are blood clots there? Echo, okay, so TEE would be best. A transesophageal echo would be best. Would give us the best picture. And then once we confirm, then we can do cardioversion. If the patient's gonna be scheduled, so can we put them on anticoagulants? Yes. So they're all described here, all right? I won't read the whole thing for you. Defibrillation. Oh, the difference again between another difference is the voltage. Okay, so we have we start with a higher voltage for defibrillation. We have a slightly lower voltage for cardioversion. We can start at 50 with the cardioversion, but for defibrillator, we can start at 150 to 200 and then goes up from there all the way to 360. EPS. Remember the procedure called ablation therapy? Catheter ablation? Okay. So before they can do that procedure, the patient has to have an EPS, which is electrophysiology study. So we have to find where the errant impulses are coming from first before we go to the cath lab and burn those suckers, right? Pacemakers. So who gets pacemakers again? Third degree, definitely. Who else?